Hello and good afternoon. Welcome to Penn Medicine's Continuing Opioid Use Disorder series and to today's panel discussion, Barriers in Care Addressing Health Inequalities in Treatment and Recovery of Opioid Use Disorder. My name is Andrew Deal and I'm an Associate Director for Development with Penn Medicine and have had the distinguished pleasure to work on today's panel with our faculty and series moderator. We have an information-packed session today, so on behalf of Penn Medicine, I sincerely thank you for joining. We have a large number of pre-submitted questions from those who have RSVP'd for this event, so it is our hope that this discussion will cover most of them. We will try to have a Q&A session following the group panel discussion, but we hope that this session will be informative. And I do invite you to please feel free to use the chat box as we will try to answer as many questions as possible if time will allow us. But to move on to the good stuff, I'd like to introduce our moderator and panelists. We are once again joined by Dr. Hallie Edelman. Hallie comes to us today with a PhD in education and as a celebrated author and documentary filmmaker. She has served as moderator in our last two opioid disorder events, and we are so pleased to have her again. And to introduce our esteemed panelists today, we have Dr. Jeanmarie Perrone. Dr. Perrone is a professor in the Department of Emergency Medicine and is the director of the Division of Medical Toxicology and Addiction Medicine Initiative. She is also the director of Penn Medicine's Center for Addiction Medicine and Policy. Dr. Kit Delgado is an assistant professor of emergency medicine and epidemiology and is an attending physician at the Penn Presbyterian Medical Center. He also serves as the co-chair for Penn Medicine's Opioid Use Task Force. And finally, we have Dr. Judy Chertok, who is an assistant professor and associate program director for the residency in Department of Family Medicine and Community Health at the University of Pennsylvania. She's received multiple awards, which Hallie will get into more, for education and primary care, and is boarded in family medicine and addiction medicine. With that, I would like to take myself out of this conversation for now, and I would like to welcome you once again, and thank you everyone for joining today. And I would like to officially turn things over to Hallie to take it away. Thank you.
Thank you so much, Andrew, and it's nice to be here with everyone. I'm so excited to be having the opportunity to interview such incredible thought leaders from Philadelphia. These doctors are making a difference, thinking forward, impacting lives on a daily basis, and really setting trends for the future for other doctors and other healthcare systems to learn from. So I would love to start, as Mr. Deal said, with Jeanmarie Perrone. And Dr. Perrone, let's jump in.
Hi, thanks for having me.
Thank you so much for being here with us. We know that you're a great physician in the ER, and you've also served on National Task Force for Opioid Use Disorder. So it would be lovely to start with, in a city, oftentimes the ER is a snapshot of the trends of what's going on within a city's drug use. So it'd be wonderful to hear straight from your mouth, what have you been seeing in the emergency room at Penn Medicine?
Yeah, it's a great question, and I think it is true that we are the lens for a lot of the opioid use disorder challenges that have happened to people. So we're seeing a rising number of non-fatal and unfortunately fatal overdoses, and a shifting population now really more affecting the communities of color around our hospital. Many of these are the result of fentanyl, which is 50 to 100 times more potent than heroin and has essentially replaced heroin in the drug supply. So what happens is that people come to us and they might not even be aware that they're using fentanyl. They might have bought pills on the street. They're not commonly, using substances, but they might occasionally, buy something and be completely unaware that they're taking, with 1 or 2 pills, a life-threatening risk. So pills are being pressed into something that looks like Percocet and is actually completely just pressed fentanyl tablets. We also see people who are seeking treatment for their substance use with nowhere else to go. We are open 24/7, and so we are a safety net for people who don't know where to turn for their substance use disorder. And I worked on Monday evening and saw a young man with high fever and dehydration, but he had delayed coming in for several days because patients face a lot of stigma and judgment when they're facing an illness, and they really try to postpone coming to the hospital if at all possible. So we still see that, care is stigmatized, and there's a lot of judgment that we need to work on to enhance our ability to provide care in all healthcare settings.
And as far as the care that you are providing, I know that you've been a big advocate of using medication for the treatment of opioid use disorder. Can you tell us about what types of medications are available or possible for people who are struggling?
Yes. So, previously to about 2 or 3 years ago, we would have, had that patient who came in seeking help, get kind of a piece of paper that says, stop using drugs, call your family doctor. But, we knew most of our patients really didn't have family doctors and that this was kind of an empty referral. So we started using some medications in the emergency department that starts patients on their trip to recovery. So there are 3 medications that are FDA approved. One is methadone, which is what we call a full opioid agonist, so acts very similarly to morphine or heroin. But it is a clean supply of a drug. It's oral, and it's provided in a usually an opioid treatment program. So they have to go to that program every day. But it's not something that we can use very readily to initiate treatment in the emergency department. One of the other medications is naltrexone, which is a full opioid antagonist. So it blocks the use of the opioids, but it's very difficult to get people started on it because they have to be opioid free for at least 7 days. So the middle of those 3 choices is buprenorphine, which is a partial agonist, so somewhere between methadone and naltrexone. And it actually treats cravings, treats withdrawal, prevents the euphoria associated with opioids, but creates a safe medication that can be taken every day or twice a day to treat opioid use disorder. And we can start that medication directly in the emergency department. So that's what we've been doing.
And when we're starting these medications in the emergency department, I mean, some people are saying, oh, wait a minute, we're just kind of trading one drug for another drug. What's your thought when somebody brings that up in this conversation?
I think it's an easy point to address when you think about it in the big picture. I can understand why people might have that thought, but what happens is there's a lot of chaos associated with addiction. The behaviors associated with finding the drug that you now have to use every 2 or 3 hours results in, the inability to do anything else, the inability to be with family or to take care of your children or to work. And so interrupting that chaos of addiction with medication can really allow people to return to those important functions and to be stabilized and, not have that challenge of, every few hours being so disruptive and creates the disease of addiction and the chaos that we see.
So almost a better option is what you're saying, is to kind of get on a path where people can, from these medications, maybe become stabilized or function in a healthier way than without them?
Absolutely, not just a healthier way. They are, what they say is they just feel normal for the first time in many months or years. So they no longer feel high, but they feel stabilized because these opioid medications change the brain over time, so that there is a big deficit when they don't have those medications, and it takes a long time to rebuild their normal neural circuits in order to regain the function that they had pre-opioid use.
And we hear the term harm reduction a lot. I know that you're an advocate of harm reduction and also education. Can you explain, because I originally thought that harm reduction was maybe using one of these medications, but can you kind of give us a broader picture of what is harm reduction?
Harm reduction is kind of broadly a group of strategies that limit the risk of everyday life. I think a lot of people use the example of seatbelts, mitigating the risk of a dangerous car crash. We use harm reduction tools every day in terms of for patients who inject drugs, we want to provide syringes because that's actually incredibly cost effective to prevent the transmission of HIV or hepatitis C. So safe, clean syringes, naloxone in case somebody overdoses. We can't really help people who have had a fatal overdose, but if there's naloxone around, that patient would be revived and be eligible to continue their journey with possibly some of these medications. And then we think it's harm reduction to be on these medications, even if they're not achieving every one of their recovery goals. Just taking that medication and decreasing their use from 6 times a day to 3 times a day, that's harm reduction too, and that protects them from fatal overdose. So harm reduction comes in a lot of flavors, but we need to embrace that concept that not everyone is going to achieve the same goals overnight, and that it's going to take time, but moving in a positive direction, we need to really support that and reward that.
Okay, thank you. You had also told us in the past when we had spoken in another conversation that you were looking at a new formulation of medication for treatment of opioid use disorder right in the ER. Can you give us an update? Where are you with that, and what have you been seeing since we talked about it the last time?
Yeah, it's really exciting. This is one of the first new formulations of treatment that have come out in a long time. It's still under an investigational drug status, but it is an injection form of buprenorphine, or otherwise known as Suboxone is the trade name. And it comes in a formulation that is injected and lasts for 7 days. So it's a little injection right under the skin. It's really well tolerated. And we're comparing how people do with that compared to the normal care, which is starting on the medication that they have to take every day. So you can see that it would certainly enhance if you've taken a medication every day. It's hard to remember to take it. So right off the bat, it has that ability to decrease the challenges of remembering to take it. And it also means that on day 1, if they get the injection, then on day 7, they can follow up with a primary care doctor and be ready for next steps in treatment, and maybe even a longer acting formulation, a 1-month formulation that can really stabilize their use. So we've seen that patients do really well on it. Patients want it. They come to us seeking the injection. And I think that it's really well tolerated. They have very little, discomfort from the injection or any adverse effects. But we don't have official data because the trial is still going on at about 20 other sites around the country.
Okay, so we'll keep checking in with you about it. It's
Please.
Amazing. So the other thing we were talking about over COVID, just the spike in overdoses that you had seen another time when we connected, and just how many creative partnerships and initiatives came out of that time period, so that people could access help in different ways. Will you share with us some of those partnerships and initiatives that you found fruitful from that time period and beyond?
Yeah, it's really amazing. This is one of the few COVID silver linings for us. There was an immediate relaxation of policies around prescribing of opioid medications because of, obviously the limitations of getting to healthcare settings in early March of 2020 and extending even to the present day. So we were able to rapidly pivot where we knew patients didn't want to come to the emergency department. So we sort of created a virtual safety net through telehealth. And over time, we've been able to gain support for a telehealth provision of the same kind of care that we do in the emergency department. So people can call in. We've partnered with Penn Medicine on Demand, which is our virtual urgent care. And all of the nurse practitioners on that line have learned how to prescribe this medication. They've really embraced this and have been just wonderful partners. And so we can, the first call goes to a substance use navigator, which is one of our people with family or lived experience, and they can navigate the patient. And if the right answer is start on a medication that day, then we connect them with Penn Medicine on Demand, who interviews the patient, has a virtual telehealth visit with them, and orders that prescription to a local pharmacy. And then if the patient needs help, we can help get them to the pharmacy and help with subsequent navigation, and then hand them off ultimately to a primary care provider to continue that journey. So it's really been a much more patient-centered, less stigma environment where we can provide that care. And it's been really exciting because not just here, but in Pittsburgh and in Rhode Island and several other areas around the country, they have also created this kind of virtual safety net. So we're excited to hopefully continue that with support for those policies to be more officially made into law.
And how could I, as a patient or a layperson in the city, find out, how do I access the telehealth system? How would I know about it?
So we do have it posted on our website. Our website is penncamp.org. The phone number is 484-278-1679, which is not really a lot of repeating numbers, so it's kind of hard to remember, but we can post that in the chat. And it's also posted if there's the 1-800-GET-HELP-NOW number for the state of Pennsylvania. Some of those local calls for Philadelphia County actually will get ultimately referred to us. So if somebody is more formally looking for help, we have tried to replace the longer pathway that was with our same-day treatment via this Care Connect line.
All right, so I'm going to repeat. It's 484-278-1679, right?
Very
okay.
true. Yes.
And then hopefully it'll also get into the chat in case people want to learn more about it. And
Yes.
before we move on, I mean, it's amazing because you see so much in the ER, and you see people at really hard points, low points in their lives, and right after overdose. So what inspires you? We hear about families in cycles and individuals in cycles, and just the challenge of opioid use disorder and substance use disorders. So what inspires you to keep going in this work and to have a deep hope for the patients that you see and their families?
Yeah, I mean, I think we've learned so much from patients in recovery. Some of my literally favorite colleagues are people in recovery who have taught me so much about this, what a patient needs and how to approach this. But, chronic diseases, cancer, heart disease, diabetes, being a patient with any one of those problems is so difficult. We see patients who come in repeatedly with elevated blood sugars and not taking their insulin, but we don't ever say, this is your last chance. I'm not going to write another insulin prescription for you. So it's really, the opportunity to change the paradigm around substance use treatment is really there for, those of us who are interested in this work. We see rapid change in people, but very few people know that treatment is available. And so being able to provide treatment in a compassionate way in an accessible setting is really motivating to me, and it's really been inspirational to see the change that has been accomplished for some of our patients.
Well, it's inspiring just to talk to you, and it's great to hear all the work you're doing in our city and just your tireless efforts for your patients. And to contribute to the field. You're kind of amazing, Dr. Perrone, so thank you for joining us.
Thank you. I'm here with a bunch of great colleagues, so it's a wonderful opportunity.
Yes, and one of those colleagues is Dr. Delgado. Dr. Delgado, we're so excited that you're here with us tonight. Dr. Perrone is really on the front lines with patients, and you've worked with her on the opioid task force to really ask deep questions about what type of data do we need, what type of research can we apply, how can we explore even better access to care, more responsible care, and making sure that patients are engaged in their care. So thank you for joining us.
Well, thank you, Holly.
So a lot of your research, Dr. Perrone shared with us the increase in overdoses within the Black community that she's seen throughout this time period, and just noted that for us. So we can't help but not ask the next question of, can you give us some sort of overview to the barriers that we're seeing for members of our Black community? What have they traditionally faced to be able to access care and quality care?
Yeah, no, that's a great question. I think we can first start with just some national facts and some of the research that we've done. We did recently a national study where we looked at a population who all actually had insurance. So this is people who should have the ability to access care. And we looked at patients who came into the ER and had an overdose. And if you take that full list of patients who had an opioid overdose and then follow out 3 months later and see, okay, how many patients actually got into any kind of treatment for addiction. Out of those 100, only about 20% or even a little bit less had any kind of follow-up. And then when you look at the people who had any kind of follow-up, white patients is the highest rate, and then black patients half as much. And it's just a disparity not explained by insurance. And so, why is that? And so I think first to understand why there is a disparity, you have to understand what the barriers are in general, and then there's some specific barriers faced by Black and Hispanic patients. So in general, as Jeanmarie so well pointed out, on the patient side, there is a feeling of stigma, and when you're actively using drugs and require drugs to feel normal every 2 to 3 hours, you really don't want to go seek treatment, and it's really hard to break that cycle. Now, for patients who are Black, they have oftentimes experienced discrimination in treatment, a feeling that they're, instead of a chronic disease, that their drug use is, a sign of criminality, and the data show that they're not offered treatment as much, whereas white patients are offered treatment more, and because of those past experiences, don't seek treatment. We also know that there's structural racism. We know that, as Jeanmarie pointed out, buprenorphine makes sense because you can take it at home. You don't have to come into methadone clinics every single day. I've had patients tell me that, because they have to go to methadone clinic, they can't also work because it interferes with their work. And what we know in terms of providers who are licensed to prescribe buprenorphine, they're much less likely to be located in racially segregated or Black neighborhoods. There's a structural factor of decreased access to care for those patients. So all these things come together and sort of contribute, at the interpersonal level and at the structural level to these disparities. So what do you do about it? And so what my role in the health system, I also help co-direct the Penn Medicine Nudge Unit, which we try to make the right thing to do, the easy thing to do. And so what we've tried to make happen in our ERs and been successful is, okay, we know that when patients are seeking treatment and we want to connect them to treatment, one of the first things we have to do is stabilize the opioid withdrawal so that they can now follow through with treatment and do all the long-term hard things to do that you need to get into recovery. But until you stabilize that withdrawal, it has a low chance of happening. And so we started, so Jeanmarie led this program where we got all the doctors in our ERs licensed or qualified to prescribe buprenorphine. The second thing that was done was that, and I see this in the chat, but we have peer recovery specialists in the health system. And what we did is that we developed automated alerts that when a patient was potentially eligible for treatment, we would ping the peer recovery specialist to engage the patients in treatment in the emergency department. And the combination of those two things basically increased the use of these guideline recommended medications sixfold in our departments. It was a dramatic increase. The next thing that we did was to help close the treatment disparities. We made treatment the default. And so through focus groups with nurses and with doctors, we actually now, as part of our, when patients check in through triage, we have a sort of a standard battery of questions that are kind of public health screening questions. We ask if there's any abuse at home, but now we also ask if they're struggling with opioids, and we ask that to everybody. and we want to make sure this was okay with patients. And what we found is that before, sometimes patients were getting asked, but it tended to, there was a bias in who got asked. Now we ask everyone, and we're actually doubled the number of people we've identified who have opioid use disorder in the emergency department. And now that we have this, we trigger clinicians to now engage patients in treatment. So we further have increased actually by 30% the proportion of patients who get onto these treatments. And then the last thing that we're doing now is trying to make it easier to connect with the outpatient treatment. And so Jeanmarie's helped set up these telehealth services, and we're actually working on a process by which to automatically engage patients with those telehealth services once they leave the emergency department.
And was part of that, I think we had talked before, just want to make sure I understand, is part of that kind of you're doing additional reach outs to patients so that if patients typically didn't follow up with care, you're prompting them to make sure that they are following up to make sure they're receiving the medications. Did I hear that correctly when we were talking? No.
That's what we're working on now. I think we've done a pretty good job of really, at least at Penn, really trying to engage the most number of patients we can and doing it in a universal way and closing the disparities in who gets offered care and provided with prescriptions and make it as easy as possible. On the back end now, we're just about to start testing an approach where if a patient has a phone, basically engaging them in a text messaging program where we ask them, have you had any problems picking up your medication? Do you know where you're supposed to be for your follow-up appointment? Do you have any issues with transportation, food, or shelter? And automatically checking in with them, and then trying to, if they have any problems, it just pings the on-call person in our Center for Connected Care to engage that patient and help facilitate their treatment. And so trying to do this in a universal way so that we automatically engage everyone will hopefully close those disparities that have been observed nationally and will help eliminate those.
Great. The other thing that you had mentioned when I asked, what do you hope could be initiated for every patient with opioid use disorder? You mentioned an addiction medicine consult service and a bridge clinic. Can you explain those ideas and share how you think they could be used effectively?
Yeah, I think that's, if I had to sort of envision and sort of putting my hat on in terms of the overseeing the opioid task force, and is I think the health systems that have made sort of major gains in this area in terms of adequately caring for the needs of our patients. And these are kind of two things. So to start with the addiction medicine consult service, and that I think we can have Judy and Jeanmarie speak to that because they're really leading that effort. But patients who are coming in using fentanyl are using an amount of drug every day that's equivalent to almost 1,000 milligrams of morphine, which is just an insane amount. And if they come in, like Jeanmarie highlighted, a patient with a fever, or if they have an infection and they want to get treatment for that, once the fentanyl wears off, you have to dose them with medication to keep up with the opioid withdrawal. And sometimes it requires very high dosages, and even really good clinicians don't feel comfortable with that. And so having expert clinicians who are addiction medicine boarded available for consultation to be able to help guide providers what has been demonstrated in studies to improve outcomes, help keep patients engaged in treatment, reduce the likelihood that they fail treatment and need to come back for something else. And just like when we have complex cardiology patients, or someone has a heart transplant, we can call a cardiologist. It's the same thing with patients who have very, very severe disease. And so the they're working on this, but it's sort of aligning the resources to making this happen is something that we want. And then having a bridge clinic, I think, is also helpful. In our health system, we have a variety of different places, primary care and some specialty addiction care where patients can go, but it requires a lot of coordination. And what some health systems have set up is essentially a single destination where you can basically tell a patient, here, show up here tomorrow, and they can get immediately bridged into care. To some extent, what Jeanmarie set up through telemedicine is functioning in that way, but also having a physical environment where patients can also be seen would be very helpful in sort of further getting patients into treatment and engaged in treatment after they leave the emergency department.
Well, thank you so much for your research. I know when we had spoken at another session, you also talked about your research on helping doctors and healthcare systems just understand responsible doses of medications post-surgery in all different, areas of medicine. So you're not only contributing to patient care, but also the broader mindset of, what's smart and responsible when we are prescribing opioids. So thank you so much for your contributions. And you talked about having a physical space for people to go to, in addition to telemed, and in addition to maybe a short-term care space like the ER. And that hopefully leads us right into talking to Dr. Chertok. I'm excited to tell everyone that Dr. Chertok is the primary care doctor of the year, which is beyond exceptional. And I think by the end of us talking to her, you will certainly see why. At the very least, you'll see her deep compassion and just amazingness. So, so let's jump in with Dr. Chertok. Dr. Chertok, can you tell us, you actually did something unique back in 2017 and started this family practice at Penn Medicine, whose practice also treats patients with opioid use disorder and allows them to access medications like Suboxone or buprenorphine, like Dr. Perrone had led us into. Can you tell us about your practice and why you decided to make this type of care accessible in family medicine?
Thank you so much for the kind remarks and for inviting me to join. I'm really excited to share the work that we're doing. I'm a family doctor, and for those of you who don't know, that means I take care of families and babies, pregnant women, geriatric adults. And so we see it all, just like in the emergency room. And doing that work for a number of years, I think we're all aware of the nationwide opioid epidemic and overdose epidemic, but it hit Philadelphia around 2017. That was really when we first started to see fentanyl and the overdose rate hit. And we saw that in family medicine. We saw that in our hospital. We saw that with our patients. And Jeanmarie and others were working on setting up systems in the emergency room to find patients, start them on medications, and they really needed a place to send them. And we all came together, and I was excited to be one of the early primary care doctors to do this work. And what we did was we educated ourselves, and we worked collaboratively with a team, and we started doing this care for our patients. I will say I had a patient ask me for it, and that was the linchpin. After feeling that there was a system-wide approach to this, I had a patient who said, I will prescribe this medicine. I heard it's great, but I want it from you in primary care because this is where I feel comfortable. So we started doing this work in 2017. Fast forward to today, there's such a need and it's such a good fit for what we do that we now have kind of 4 different half days at our practice at Penn Family Care, where we only see patients with opioid use disorder. We have a dedicated session, we have residents, and through this work and our expansion, we've seen over 200 patients in the last year. And just like our family medicine patients that span it all, our patients span it all. So we see people in their early 20s. We have a number of patients in their 70s, and we see people throughout their lifespan.
Amazing. You talked about the need, and when we talk about inequality in healthcare and people feeling like there is a stigma, and maybe within the Black community, the idea that people have felt criminalized for, having a substance use disorder, an opioid use disorder. And part of the work you do that I found to be just really important is your work where you're going into the community and you're making sure that you're building a level of trust. So can you talk to us about the partnership you have with Prevention Point and what you do when you go into the community?
Yeah, absolutely. So I'm really lucky to be a part of a project with Prevention Point, and a really great model of an academic community-based partnership. The Prevention Point Philadelphia, for those of you who don't know, is a harm reduction organization in Philadelphia. They provide a wide array of services. One of them is the project that I'm involved with, which is called the Surge Bus. So we are a group of a large team, and we go look at data of overdose rates in Philadelphia, and we move to that area. We are a van, and we go where there's overdoses. And what that tells us is this is an area that doesn't have access to harm reduction services and doesn't have access to treatment. So we move to these locations, and we first and foremost provide those harm reduction services. So the naloxone that Jeanmarie mentioned earlier to treat overdoses so that they are not fatal. What's something called fentanyl test strips, which allows people who are using substances to test what's in them and to know what they're doing and how to keep themselves safe. And lots and lots of community education. So we go and do all that. And the final layer of that is if there is someone who walks by or hears about us that is interested in treatment, we're able to start Suboxone, the medication for opioid use disorder, right then and there. And what we do is we see a panel of patients in their community site for a few weeks. We provide their medication. We have the most wonderful team that provides harm reduction services, intensive case management services. I've seen miraculous mountains be moved for our patients. And then we transition them usually to a primary care-based setting after a period of stability.
And, you talk about this period of stability that you see in patients after meeting them in the community and on the street. So, it makes us hear, like, there's so many times we hear that someone on the street might be too far gone to get treatment, and when you talk about patients getting to a period of stability, like from your vantage point, how does that happen? Is it possible for someone in the street in these high overdose areas to make change? Like, what does it take for patients to realize success when they're at that place?
Yeah, it's a really important question, and we hear the scary numbers of what's happening out there, and we don't hear the good stuff. I think there's a couple layers of this. One is we have a responsibility as a healthcare professional, as a society, to try to reach everyone, and we know that some of the people that you're describing are in the most need. I'll also say that people who face these challenges that are unhoused and substance use are among the most resilient people that we'll ever meet. When we think about what it takes to get through a day on the street, I think we can imagine all the pieces of that. And so coming to people who are in those situations and recognizing their strengths and their value is the number one step. And once we come to that with respect and kindness, what we see is that if there is someone who's in a place of readiness, we're there for them and it's easy to access. So there are people who are really tired of that cycle and are interested in treatment, but the steps it takes to make a phone call, make an appointment, even go to an emergency room are too much. And so if we happen to be right there, that lowers so many barriers. They don't have to make an appointment. They don't have to call first. We're literally right there. So that is, it really is amazing. And I think our program is most geared towards the people who aren't able to access services in other ways. And then, I think we all know that this is opioid use disorder is a chronic, serious disease. It takes many people multiple attempts at recovery. So what I think our team can do and being in the community can do is providing for our patients, either a bridge towards treatment and recovery at that moment, or if not, social services that they need, harm reduction services that they need, a positive experience with the healthcare provider, a positive experience with the medication, and all of those things might eventually down the road lead to a period of recovery.
And is there a way that we can better serve all patients? Is there a better way that we can serve more members of the Black community? Is there a better way that we can have more equitable healthcare? And how do we do that?
The $1,000,000 question. I think the first thing is we have to ask that question, and we need to ask that of the community, and we need to listen hard to the answers. And we work, as Jeanmarie mentioned, with many members of our team are themselves in recovery. We have many members of our team who are members of the Black community. It starts there, having those members of our team, and then also, again, asking and listening. So that is the number one most important thing. And from some of those conversations, I think the additional things that I've learned are that we need to be addressing and offering harm reduction services for all substances. Opioid use disorder is front of mind right now, given the crisis, but there's been an ongoing crisis of stimulant use disorder and ongoing overdoses related to that, and we need to be addressing that, which is particularly affecting the Black community in Philadelphia. And I believe that expanding access to Suboxone in these community-based settings, but also in primary care, is a really great way to reach people who have not traditionally had access to services. And when they come, we need to do a good job.
Yeah, that's what I was going to ask you. Once you have your patients and you're, so lovingly treating them, how do you encourage long-term success? Because that's the other thing we keep hearing about, like these quick cycles. Someone finds some success and then overdoses again, and finds success and overdoses again. What's needed, or what ways do you kind of encourage long-term success for your patients?
Yeah, so there's a lot of elements to that. I think the first goes back to the team yet again. This is a hard disease, and there's so many people that can help to treat our patients. And so I think the heart and center of our team is often our peer recovery specialist and someone with lived experience who connects with our patients, who forms the glue to our clinic. That's an important component of what we do. And then there's the medical assistant, there's the front desk, our pharmacist, our nurse. Everybody has to treat our patient with compassion and make them feel welcome. And then that relationship is huge. So when they have that relationship with me as the provider, but also the rest of our team, it goes such a long way. Every visit should start and end with, like, we're so glad you're here, and to welcome our patients and to congratulate them for the difficult step it takes to get to each and every appointment. So I think that's really huge, and it does, I think, a lot come back to the relationship. There are other kind of specific things that we do. Jeanmarie talked about harm reduction quite a bit. And I really think of harm reduction as an attitude and a philosophy as well. So that means that we take the patient where they are and we try to meet their needs, whatever they are in the moment. And if we have that philosophy, that leads to flexible appointments, asking people their goals. It might mean treating their medical issue that day and not even talking about their substance use. So I think that philosophy really makes a huge difference to our patients. And then lastly, trauma-informed care is something we think a lot about in primary care. We recognize this is a group that has had significant trauma. And so we need to create environments that feel safe and comfortable for our patients. And I think that's one of the really important pieces.
So what have you seen in your practice that you find to be positive and can provide hope to community members and families who have someone struggling, and even individuals who are struggling?
Yeah, I'll speak personally. For me as a doctor, working with this population has been one of the most incredible things that I've ever done. When I kind of meet someone when they're really struggling and then get to cheer them on as they find their success in life, it's incredible. It really is truly amazing. And there are just countless examples of people that have made so much progress, and I've got to be a part of that. One example is a gentleman that I met through my Prevention Point project. He literally was walking by on his way to purchase substances, met us, we chatted with him. He came back the next week and asked to start medication. We saw him for a few weeks. We got him an ID and a phone, and he did well, came to our office, saw him a couple weeks in the office, and he had a relapse. We didn't hear from him. We tried reaching out. We told him, we left messages. We're worried about you. How are you? Where are you? We didn't hear back. And then 6 weeks later, he came back to our mobile unit and said, I had a slip, but I'm back and I feel comfortable with your team. He reengaged in the community site, came back to the office, and I've been seeing him for a year in the office. So just one example of what this can look like. But again, just so many others. I have a patient in public health school. I have a great patient who just graduated law school. I have a patient who had a baby at 1 a.m. this morning, had a healthy and safe pregnancy. She had her baby. Yay, congratulations. I have a patient who was not successful with medication, but his hepatitis and diabetes are treated, and he is thinking about re-engaging in care. So the stories are endless, and they motivate me each and every day.
Mm. Well, it's kind of amazing. I'm sure most people are thinking, how can we clone Dr. Chertok? But I guess it also just really makes me think about your work, that you're not just with your heart caring for your patients and then also making sure you're going into the community, but you're also thinking about the next generation of family medicine doctors. So can you talk to us a little bit about your work with the residency program that you're involved with, and also the fellowship that you're working to establish?
Yeah, thank you so much for asking that. It's so important. These skills and these things that I'm talking about are teachable and replicable. And so we need to be doing that so we can more people can access these services. We have intentionally incorporated our residents into each and every bit of the programs that I explained to you. And this is to expand the army of people who can do this work. What's amazing is I introduce that concept to our patients at their visits. I say, you're going to see me each week, but you're also going to meet residents. And by allowing them to participate in your care, you are going to be training people who will then go out and provide this care for other people. And our patients embrace that work. So all of our residents in family medicine, from the beginning of their intern orientation, are introduced to this work. They get trained in how to use the medication. They spend 8 to 10 half days a year with me and our team in the outpatient setting. They work with these patients at Prevention Point, also about 8 sessions over their training. So they are seeing this from lots of angles. They've embraced this. It is something that they really enjoy. And many said they didn't come into residency having an interest in this population or thinking much about it. And most of them have left wanting to do this in their future work. The fellowship, I think, is our next step. We have so many, again, if we can train all of our family medicine doctors to believe that this is part of primary care, as I do, our next step is kind of to dovetail on what Kit mentioned with the consult service. There's also a need for high-level specialty consultation for complex cases. There are some things that are difficult, and the drug supply keeps changing. And so we need also experts in this field. And we have so many research experts. We also need clinical experts. And so what I'm hoping to establish is a fellowship, which would be a 1-year clinical program to train those experts to do the clinical work both in the hospital but also in the outpatient setting.
It's amazing. Thank you so much for being in Philadelphia and sharing your incredible work in Philadelphia and beyond, Dr. Chertok.
Thank you so much.
At this point, I would love to invite all the doctors on for a question about how we can best support their work, and then really would love to also then lead into some of the questions that were sent into us for the remainder of our time. So Dr. Perrone, it would be great if we could also, there we go. So like we're talking about these incredible initiatives that all of you are doing and amazing ways that you're caring for patients, how can people who are listening, how can the broader community support your work or lean in their own way, in any way to this work? So maybe we can start with you, Dr. Perrone.
Yeah, I think the real easy first step is just everybody knows somebody who's struggling across every demographic. And so, respectfully trying again, reaching out to those people, letting them know that there are treatment options, not to give up hope. There really is an opportunity to start, try something new or different this time. And I think that offering that support to family members of loved ones to sort of reach out again when they've kind of already felt like they can't do that, offers hope to the families and can offer, hope and another chance to patients. We have great medications. We have great great providers, and hopefully we have low barrier care. There was a question in the chat about how people pay for this. And essentially, it's pretty inexpensive. These medications have been off patent and are really relatively inexpensive compared to a lot of the other things we do. They are covered by most insurance companies, and a lot of the work we do via telehealth is free. So everyone is eligible for care, starting this care.
Great. Dr. Delgado?
I would say, in general, as a society and like a U.S. healthcare system, we think about drug overdoses being the #1 cause of death now for people under the age of 45, and think about the investment of resources that we put into taking care of patients in outpatient settings or in the hospital. There's just a mismatch between sort of the level of public health emergency we're in right now and sort of how it's still, like, from reacting to it and putting the resources in place, so that we can provide the same kind of resource when someone comes in with a heart attack, a very protocolized care, bells and whistles go off, people come in from home, to open up a cath lab. The mortality rate's about the same, when someone comes in for an overdose within 30 days as a heart attack. And so I think, having the resources in place so that you have a specialist that, if you're a non-expert, it's a specialist that you can call to best provide care for that patient, whether you're in the hospital or the outpatient setting. The clinic resources to get people into treatment when they're motivated, and sort of like, once you've gotten someone motivated into treatment, like helping to keep them there. And I think it's really just a culture shift and sort of, putting the resources to where the problem is, and the problem is huge right now. And so it's just a mindset about, addressing the problem.
Dr. Chertok?
Yeah, I echo the above. I'll add to Jeanmarie's Narcan. Anybody on this call get some at the pharmacy. You don't need a prescription, and have it with you wherever you go. If you live in Philadelphia or anywhere in the country, you should have it. And to add to Kit's, that mismatch of investment is really, we see that across our health system and across, I think all of the health systems, that this is the emergency and we're not focusing on it in the way that I think we should, and that we could see success if we did. Things like a consult service save lives. That's pretty remarkable, and we should be, as a society, as systems, focused on that as our highest priority. And then to bring it to primary care, this should be, I think, offered, I hope, at one point at every primary care office all across the country. I applaud my own specialty for including this in new requirements. Just hot off the presses, so all residents are now required to learn how to do this. And so I hope other specialties will take that on, and I hope that family medicine around the country and primary care will take this on as something that everybody should do. And then finally, we need to be investing in our communities that are most impacted and listening to them and providing community resources.
Thank you. Well, let's jump into, there are a few questions in the chat and also questions that were sent in advance. So let's take a couple of those before we wrap up tonight. Somebody in the chat is asking us, as a person in recovery, can you share a little bit about the use of how the use of peers can benefit people seeking treatment, since Penn is using some peer support? So I'll open up to any of the doctors who want to take it.
I can say our peers are a wonderful group of people in recovery, and it was, I think, identified many years ago that people with lived experience, are great to guide people in the subsequent journey. And so a few years ago, there was a grant that provided the opportunity for these peers to be in our emergency department to facilitate the handoff from the emergency department to Judy's office kind of idea, so that they would meet them in the emergency department and then they would meet them again, or make sure that they got to follow-up care, with Judy or someone else. And it's really impactful for the patients who are, meeting not just a clinician who's compassionate, but somebody who's been through that journey. I have on many times done my best to convince a patient to try Suboxone, and they say, you know, no, not today. And then a peer walks in after me and comes out 15 minutes later and says, oh yeah, they're ready to do it. So, I mean, despite whatever I do, I'm never going to be the same as somebody who's walked that walk and been in that journey. So it's really impactful, and it's wonderful for, you know, those of us who work together to hear about these successful handoffs, and then to hear back from, you know, Judy about patients who are in care because of the peers. So really critical part of the workforce, and obviously a great career path for people in recovery.
And we've heard oh, go ahead, Dr. Chertok.
Oh, I was just going to say, and they train us. So I thank all the peers for teaching us so much about how to care for our patients.
Dr. Chertok had taught me that originally Suboxone was kind of more pay to play, you know, like a pay, it cost more money when it first started, and therefore less people were able to access Suboxone. Can you talk a little bit more about Suboxone? Suboxone, is it more accessible now? How much is Suboxone? People are in the chat and also on, who've written in before asking how to access Suboxone cost effectively. So can you talk to us a little bit about that piece and how it even works, how you got started on Suboxone?
Sure, I can take that. Yeah. So when it first was available, it was available outside of a structure like a methadone program where someone to go every day, which was incredible. But doctors didn't know about it, didn't feel comfortable prescribing it, and it sort of got set up into private clinics, and that was pretty typical way for people to access it. And often they were cash clinics. Maybe the medication was covered by insurance, maybe it wasn't, but that was the way it first came out. I had a patient who eventually transferred to us who told me he found like one doctor in Philadelphia 15 years ago who he had to like pay cash every single visit, right? So it was really inaccessible to a lot of our patients that we're talking about now. But again, at this point, it is, easily prescribed in primary care or other settings, and it is very readily covered by insurance. And luckily, Pennsylvania has made this covered for all of our Medicaid plans without a prior authorization. So there's really very little financial or insurance barrier to getting it at this point if people can access the providers who are doing it.
Well, also say too, for patients that come into our emergency departments at Penn seeking treatment, even if they don't have insurance, we will put the prescription in our outpatient pharmacies, and we've gotten, Jeanmarie and others have gotten funding lines such that even if the patient doesn't have insurance, we will still dispense the buprenorphine. So really trying to lower every single barrier, financial and otherwise, to help patients out.
And before we turn the program back over to Andrew Deal, is there something that we missed or something? Well, obviously there's a pretty big topic, so I'm sure we missed a lot of things, but is there something that's important to you at this moment that we didn't cover that you would love to just share with the people who have attended? So maybe Dr. Delgado, would you like to start?
Yeah, I think that, there's a lot of opportunity. I think that one area where we need to invest more in, it was touched on by both Drs. Perrone and Chertok, was particularly the escalating overdoses in the Black population, and really tied to use of cocaine and stimulant substances. And sort of we need to do, I think, more to engage patients, not just opioid use disorder, but thinking about drug use more holistically, and thinking about harm reduction strategies for patients who come in thinking they're using cocaine, but actually it's something laced with fentanyl, and getting test strips and other strategies to help them more with their their stimulant use disorder. And by doing that, we can reduce overdose deaths that are associated with fentanyl. And I think that's kind of one big area that as a country we need to move towards.
Thank you. Dr. Chertok?
I'll just say I'm heartened to see a session like this happening, and to really putting this issue front and center, talking about it as a community, and thinking about options to move forward. So I'm appreciating this moment that we're sharing together.
Thank you. And Dr. Perrone.
Yeah, I mean, it started a while ago, but it's amazing to have a big team of people who are so interested in this work. And, you know, we have subcommittees on stigma, we have subcommittees on harm reduction. Like it's great to see the you know, interest and growing, you know, understanding that we need to socialize medications, opportunities, treatment, and recovery. It does happen, and you know, the narratives of Judy's stories of success really impact everyone to believe that it can happen, and that's what we need to, I think, socialize more.
Well, thank you all so much. To learn more about this work, Andrew Deal and his team are definitely people that you could reach out to. So Andrew, we'd love to invite you back on and wrap up the session for us tonight.
Absolutely, and I want to just say thank you to everyone for giving their expertise, and it's clear that Penn Medicine has some wonderful providers who care so deeply about opioid use disorder and the research and the treatment that you do. So thank you for everything you do. It truly does take a collective community to move this research and supporting treatment forward. So Penn Medicine is at the forefront of these important initiatives, and for everyone who joined us today, thank you so much for taking the time and joining. If you do have any remaining questions, or if your questions were not answered, we will be sharing contact information upon concluding. So please feel free to reach out. If you have any questions, we will also, as it was alluded to so often, philanthropic work is super important for getting some of these events moving forward. So with that, I want to thank everyone for joining today, and thank you to our panelists and for Hallie for moderating again. And I wish everyone a happy, safe, and a wonderful evening. Thank you for joining.